Our next speaker, Professor Gerrard Visser, I hope I'm reciting it in the right way. He's going to talk about how to stop the rise in unnecessary cesarean section. He is Emeritus Professor of Obstetrics, University Medical Center Utrecht, the Netherlands, Executive Board member of the European Association of Perinatal Medicine.
Thank you very much, Mr. Chairman. The Americans indeed call me Visser. In my country, I'm Fisher. It is like the English Fisher. Fisher is exactly the same as fisherman. And that's what my grandparents indeed were in the Netherlands. A second presentation on cesarean section after the eloquent one by Professor Ismail on VBAC. I will not discuss VBAC, but we'll hear about it. But I will talk on our position paper from FIGO, how to stop the cesarean section epidemic, or more rightly, as indicated in the program, stop the rise in unnecessary cesarean section. I've already talked twice before in Cairo on the epidemic of cesarean section. And the first time I was almost kicked out of the country. But the fact that now I'm allowed to talk on it for a third time, that shows there is some hope that there might be a change in the direction of cesarean section. Because one of the previous presidents of FIGO, one of your colleagues from Egypt, has told me that in 10 years in Egypt, there was a rise in cesarean section from 10 till 60%. Incredible. I think you have the world record on the rapid rise in cesarean section. Well, overall, this is what we see in the world. A threefold increase in cesarean section between 1990 and 2015, from 7 to 21%. And 21% is not that bad. But look at the top, that's South America. Then we see North America and Australia. Green is Europe. The bottom line in yellow is sub-Saharan Africa, and the other rapidly rising yellow that we see over there is the northern part of Africa. So that's where you will also find Egypt. Most people think that cesarean sections are especially performed in high-income countries. But that's not true anymore. It's the middle-income countries. Here you see the relationship between gross national income and the incidence of cesarean section. In the poor countries, on the left side, it's very low. Then it is rising till about 25–30%. And on the right-hand side, you see the high-income countries. And they're not that high. They're in between 16 and 33%. Some are rather high. Germany, the United States, they're the highest. But Scandinavia and the Netherlands are the lowest. But you can also see that the highest incidences, and the one that, sorry, I've shown here, I have an incidence of more than 40%, are in middle-income countries. On the left side, almost all the South American countries. But on the top, on the yellow part, on the right side, you see Egypt. So indeed, you have become rather famous. I've also added to the right some recent data from other countries, and you can see that in the eastern part of Europe, but also in China, Cyprus, Greece, there are very high cesarean section rates. If you look at two neighboring countries, the Netherlands and Germany, it's 16 as compared to 32% of cases. So when a pregnant Dutch woman is driving through Germany, we always tell them, don't stop because you might get a cesarean section on the way. Continue immediately till you're home again. But this is strange. Is there any difference between Dutch women and German women? I don't think so. Still twice as high. Even within countries, there are an enormous difference in cesarean section rate. Here you see the Czech Republic, data from Peter Willewil. All 12 perinatal centers, and data from 2007 till 2014. And you can see that the top one in red increased from 32 to 40% of the percentage, and the lowest one from 20 to 22, 23%. Within one country, an enormous difference in cesarean section rate, and no difference, and I think that's very important, in perinatal outcome between those centers, as far as they could study. So, what should be the conclusion from these slides? That the incidence of cesarean section has nothing to do with evidence-based medicines. It has more to do with the income for hospital and doctor, daytime delivery, obstetrician who hated to work at night, loss of skills to attend difficult vaginal delivery, maternal request in some cases, and also medical legal issues. That's more or less the list. Increase in cesarean sections, increase in direct maternal morbidity, complications in subsequent pregnancies, uterine rupture, placenta accretion, a doubling of the incidence of preterm delivery. And here at this meeting, there is a whole symposium on the niche. The niche didn't occur until 15 or 20 years ago, and now it's a major disease. If you look at preterm delivery, if you do a cesarean section for a term breech position, you slightly improve outcome. But given the fact that during a subsequent pregnancy, the incidence of preterm birth is twice as high, you will lose that advantage already in the next pregnancy. Many doctors do the cesarean section too early, and that will result in neonatal morbidity. And there is a large body of evidence of autoimmune and metabolic disease in the offspring of women delivered by cesarean section are more often obese, 30% higher, have more often asthma, type 1 diabetes, etc. And these are data from the WHO. There's no evidence for improved fetal outcome for cesarean section rate greater than 15%. And if you don't believe the WHO, you can also go to this paper here shown on the left side from Molina et al. In the JAMA in 2015. And they indicate, well, probably the lowest maternal and perinatal problem occur in countries with a cesarean section rate of around 19%, a bit higher. So worldwide overall, if we are now at 23%, that's probably not too bad. But having a cesarean section rate of 40, 50, or 60%, that is way out. This time, I'm not going to go into detail in all the short and long-term complications of cesarean sections. In 2018, there was a mini-series in the Lancet on cesarean section, epidemiology, short and long-term effects, and on interventions, and you can all find them on the web. Also in the same issue, there was our FIGO Safe Motherhood paper, how to stop the cesarean epidemic. The rise has to be stopped. How to reduce the cesarean section epidemic. No VBAC, that has been discussed, although that's one of the options, of course. Let's start with something that doctors and hospitals don't like. That the doctor's fee for a cesarean section should be similar to that of a vaginal delivery. And financing of hospitals should also at least partly be based on the cesarean section rate. I'm not against a reasonably good salary for doctors. So I'm not proposing that health insurance should pay less for deliveries, but the distribution should be a little bit different. It shouldn't be lower for cesarean section, but primarily it should be higher for vaginal deliveries, which take a lot more time. This is what professional organizations usually cannot do on their own, opposing the government or healthcare insurance companies. But from FIGO, we are very much willing to help you. Usually, if you look at average budget of healthcare of a country, pregnancy and delivery is costing almost nothing. The Robson system has also already been used. Women should be properly informed about the risks and benefits of cesarean section. Also, Professor Ismail has indicated that. It's very important. Oh, love, let's have a cesarean section. Yeah, we can do it very quickly. I can book you in the morning and the next day you can go home again. That is a little bit too short, I think. Invest in better care. It's not cure during labor, which is the most important one. It's care for the women. Care and support, privacy, adequate pain release, and improved training and reintroduce vaginal instrumental deliveries. If I've seen it correctly, here in Cairo, the vaginal instrumental delivery rate is about 3 to 4%, something like that. I saw that on one of your slides. In the north of Europe, it's about 10%. So it's considerably higher. And if you go into Africa, it's 0%. And they do a lot of cesarean section. So let's first go for these ones, the doctor's fee, the classification system, invest in better care. And then on the next slide, we see the data from Portugal. There was a linear increase from 2000 till 2008. And then healthcare providers and doctors started with this protocol for Robson classification, audits, and also changing in the financial system. Initially, the private part of the system didn't agree, but later on, they also participated. And you can see it resulted, the overall for Portugal is the white line, in a decrease in cesarean section. Exactly the same in Iran, where the cesarean section rate from 2000 to 2014 has increased from 35 to 48%. There was no effect of maternal-friendly hospitals, standard protocols, preparation classes, etc. Then there was the 2015 initiative, natural childbirth free of charge in all government hospitals, improved privacy in the labor wars, adequate pain relief, financial incentives promoting natural childbirth, and that's very important in Iran, the cesarean section rate affects the hospital rating. So if you want to have a higher rating, you shouldn't do too many cesarean sections. Was there an effect? Yes, when it was published, there was a 10% reduction in cesarean delivery rate in 15 months. Similarly, in Shanghai, a reduction from 50 to 36%. How? Education support, adequate pain relief, and also over there, a change in the reimbursement system. And for hospitals, it's just as important as it is for doctors. Let's move to this one. This is a very difficult one. Women should be informed properly about the risks and benefits of cesarean section. I hope this example is the right one. Here is the Czech Republic. Also a linear increase in cesarean section, and then from 2014 onwards, a consistent decrease in cesarean section. So I wrote an email to Professor Wellebiel in Prague, and his answer was, I do believe that information in general, and especially information to women, was the major influential factor. Their level of being informed, not necessarily by their doctors, and maybe some wiser healthcare providers. But in the Czech Republic, it was the public. There were articles in the newspapers and of women delivering normally and indicating that there were also dangers on cesarean section, and everyone forgets them. So that's also an important issue. Improved training and reintroduce vaginal instrumental deliveries. My predecessor as a chair of Safe Motherhood, Will Stones, called it low-hanging fruit. It's easy to introduce and you will have an effect immediately. Here we are in Uganda. ventouse extraction versus second stage cesarean section, large series, maternal mortality only in the second stage cesarean section, more severe morbidity, more time delay. Apparently, they have to wait a long time before you get a cesarean section, and more cases of fetal death. And beforehand, we heard the difference between a cesarean section pre-labor and during labor. Pre-labor more likely to be associated with placenta accreta, but second stage cesarean section overall is much more dangerous for the women. This is from the Lancet, first versus second stage. And you can see there is a 5-fold increase in maternal death, NICU admission, hysterectomy, poor fetal outcome, etc. Second stage cesarean section is also more difficult overall. So this is very important. Revised instruction as to the need for continuous cardiography during labor. And these are data from California, from the United States. We know the United States is not a good example for good obstetrical care. Here we can see maternal mortality in the United States increasing, most likely related to an increase in cesarean section. And if you compare that to all kinds of European hospitals, or European countries, you see a decrease in maternal mortality. But the United States is not a very good example. But California, they're more proactive. They developed a toolkit to support vaginal births and reduce primary cesarean sections. It was a combination of better care, intermittent monitoring and low-risk pregnancy. You know, in the United States, they monitor everyone by cardiotocography and giving all the false positive that will really result in lots of extra cesarean sections, and adequate pain relief. 56 hospitals in California, and you can see there was a decrease in cesarean section from 29% to 24.5% in Robson Group 1, a very important one, singleton, vertex, term, nulliparous women. A very important one, because if you prevent the cesarean section, as indicated before in the first one, you don't have to do a repeat cesarean section. So it worked. And if you look at the bottom line, we can see the complication. The blue one on the top is chorioamnionitis. That increased slightly. But if you look at all the other ones, third to fourth degree laceration, 5-minute EPCA score below 5, severe unexpected newborn complications, operative vaginal delivery, transfusion, no obvious change, and some even decreased. Less cesarean section, no signs of impairment of perinatal outcome. In 19 of these hospitals, the initial cesarean section rate was about 31%. And these hospitals, it fell from 31 to 20% of all in this group. So it is possible to reduce cesarean sections without impairing perinatal outcome. And I think that's very important. Also, as far as medical legal issues are concerned, it's not the cesarean section that will prevent most of fetal complication. From California, some more follow-up data until the year of 2019, again in Robson Group 1, and you can see there is this continuous decrease in cesarean sections in these nulliparous term women. Audits for cesarean section, Canada, New England Journal of Medicine. Only 1.7% decrease in cesarean section in low-risk women, but the overall incidence of cesarean section in Canada is only 22%. If it's already low, it's difficult to reduce it furthermore. And perinatal outcome appeared unaffected, unchanged. Finally, 2 slides from my country, the Netherlands. In 2008, there was a Peristat report from perinatal and maternal outcome in Europe, and the Netherlands were not scoring well. Well, we were one with one of the highest rates of perinatal mortality. Then doctors woke up, and you can see here we are, the red line on fetal death rate in the Netherlands as compared to the three other lines, Scandinavia, the lowest, Western Europe, and Eastern Europe. And you can see we managed in about 7-8 years to decrease fetal death rate to the lowest in Europe. Also, our maternal mortality rate fell to incredibly low values, 3 per 100,000. There was even a decrease in cesarean section rate, not much, but it is low in the Netherlands. And there was an increase in induction rate. Why this change? Well, the doctors say, we're doing audits. Yes, but you started audits already 3 years after there was the initial report. No, in my opinion, it is just awareness. Be aware that there might occur complications. Most pregnancies are low risk, but even in low risk pregnancy, fetuses may be dying. So increased awareness without increasing operant deliveries or whatever it is, and you can improve outcome. And finally, there's good news for Egypt. Since the higher the cesarean section rate, the more likely you will be able to reduce it significantly. To reduce it from 17 to 16% is extremely difficult. But from 60 to 45%, you can do it in 2 months, 3 months, whatever it is. But please reconsider your cesarean section rate. Involve government and healthcare insurance companies. Unnecessary cesarean section are likely to increase direct and late maternal risk and to impair long-term outcome of their offspring. Thank you very much for your attention.
Thank you for this interesting lecture. But you know, the problem here in Egypt is very bad. People are doing cesarean section almost always at the private clinic or private hospital. They do it 1, 2, 3 times because they are doing family planning. Doing family planning in Egypt. They have 1 or 2 or 3 cesarean section only in high standard area like Cairo or Said. The lowest incidence is in Sohag, low social class. They show the lowest rate of cesarean section in Sohag in Upper Egypt. In economic, in rich governorates like Cairo and Said, it is the highest rate. People doing cesarean section in private sector, not National Health Service hospitals. So the problem here is very bad. Doctors are aware that they will go to the court if the baby is injured or the mother have a problem. It is multifactor, and the price also, the price. Cesarean section price is higher than normal vaginal delivery. Even in hospitals, young doctors are not trained for vaginal delivery. So in Jalai Hospital, it's a referral hospital like Asr Al-Aini, 2 rooms only for vaginal delivery and 5 rooms for cesarean section. So the problem is difficult here. Thank you.
Thank you very much. That was a very interesting and I guess a true comment. People are not used anymore to attend to vaginal delivery. So it should be a change of mind. And you cannot do that from one day to the other, of course. But financing is indeed essential. If you get more money for a cesarean section, you will do more cesarean section. If you're not used anymore to vaginal deliveries, you're afraid for a shoulder dystocia or whatever it is, you will do a cesarean section. So training of the young doctors, by whom? Probably by the older gynecologists, because they still know how to do all kinds of vaginal delivery. And indeed involve the government, because the whole system of the prices for a cesarean section or the fee for a cesarean section in vaginal delivery are essential. Thank you very much for this comment.